Test, test, test. I agree with yesterday's hearing that members need to be given a map and a watch to be on time to hearings. That includes both sides of the aisle. It's not directed to one or the other. We welcome all members of the subcommittee and our witnesses. We look forward to a very productive session today on some impactful veterans legislation. Before we begin, however, I'd like to take a moment to remember the nearly 3,000 American lives that were lost 23 years ago today. Please join me in a moment of silence for the 9/11 victims and their families. Thank you. Today we'll be discussing 16 bills. Each bill would attempt to improve the delivery of health care to the men and women who have served. These bills include creative solutions that would seek to address difficult problems, including a pilot program to fill vacant shifts, reforms to ensure that the VA has the authority to prescribe medicine, and a study which looks at the mental health crisis that affects our veteran community. I would now like to take a moment to discuss my bills, H.R. 9438, the No Wrong Door for Veterans Act, and H.R. 9478, Veterans Sports Act. H.R. 9438 would seek to reauthorize an incredibly important VA mental health program, the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. The Fox Grant Program is a successful grant program that enables the VA to provide grant funding to community-based organizations to help organizations in communities where veterans live expand the reach of their mental health efforts. My bill would reauthorize the Fox Grant Program for an additional 3 years until 2028. It would also make changes to the administration of the program, including improvements to coordination of care between VA providers and grantees, and the standardization of the veteran intake process. This program is another avenue for veterans to receive brain health support. There should be no wrong door when it comes to seeking brain health, and I'm proud to have introduced this bill to continue and improve this amazing program. My second bill is H.R. 9478, the Veterans Sports Act. This legislation would provide access to adaptive limbs for amputee veterans by ensuring that they are able to have the highest quality of life that we can provide them. This bill would amend existing law to ensure the availability of adaptive sports and recreation prostheses limbs by recognizing them as medically necessary for veterans living with limb loss. I think it's critical that we ensure that disabled veterans have the equipment and tools they need to live active lifestyles as they please in order to allow them to live the fullest and make them whole. I'm proud to introduce these bills and look forward to discussing the many others on our agenda. I want to again thank our witnesses for being here today and those organizations that submitted statements for the record. It's a privilege to collaborate on crafting impactful legislation for our veterans and to address some critical issues facing them. I now yield to Representative Sherfless McCormick for her opening remarks.
Thank you, Chairwoman Miller-Meeks, and thank you to our witnesses for being here today to discuss these bills. I'm sitting in for Ranking Member Brownlee, who unfortunately could not be here today. I know she's disappointed to not be here, especially not to be able to speak about her bill, the Have You Served Act, which is on the agenda for today. I'll take the opportunity to recognize her for her work on this issue. So often, just asking the question, have you served, can make a huge difference in recognizing and supporting veterans. Helping service providers learn how to appropriately talk about veteran status and where to connect them to resources will change lives. Representative Brownlee's bill will create grants to establish Ask the Question campaign training programs, establish key matrices for the training and improving outreach about the efforts, and I want to thank her for leading this effort. We will also consider several other bills today, sponsored by my Democratic colleagues, which will increase access to VA healthcare, especially for rural veterans. This includes the Rural Veterans Transportation to Care Act, which will expand the VA's very popular Highly Rural Transportation Grant program and expand the program to serve veterans in rural in addition to highly rural communities. It also includes the New Mexico Rural Veterans Healthcare Access Act, which would adjust VISN lines to ensure veterans in New Mexico can easily receive travel reimbursement when accessing care at the nearest VA medical facility to them. I'm also glad we are considering the Veterans Sentinel Act legislation to address suicides that occur on VA campuses. While these events are rare, they are tragic and devastating for VA and to all of the veterans community. Representative Crow's bill would create a task force to identify root causes for these events and analyze ways to stop further events from happening. Finally, we will consider a bill to give copay parity to veterans that identify as Native Hawaiians and strengthen VA coordination with the Native Hawaiians healthcare system. However, I am disheartened to see so many bills from my Republican counterparts on the agenda that focus on diverting more care out of VA. We know that VA provides the best care and that more often than not, veterans want to receive their care from the VA. Some of these bills, like the Veterans Mental Health Access Act and the No Wrong Door for Veterans Act, propose to send more money outside entities, creating grant funding giveaways with no or very few strings attached. These bills lack vital matrices to monitor the performance of grantees and ensure these programs are meeting their intended purposes. I look forward to hearing from our VA witnesses about the department's view on all these bills on today's agenda and how we can work together to ensure VA can serve veterans to the best of their ability. I'm also looking forward to hearing from our VSO partners about what these bills would mean for their members. With that, Madam Chairwoman, I yield back.
Thank you, Representative Sherfless-McCormick. We have a full agenda today, so I'll be holding everyone to 3 minutes per bill to get through in a timely manner. This morning, we are joined by several of our colleagues who will testify on their bills. We are appreciative of their work in serving our nation's veterans. With that, I ask unanimous consent that all non-committee members be waived on to speak on their bills from the dais. Hearing no objections, we'll move forward. I now recognize Representative Luttrell. You are now recognized for 3 minutes.
Thank you, Madam Chairwoman. The Service Dogs Assisting Veterans Act, or the SAVES Act, would require the Secretary to establish a 5-year pilot program that would award competitive grants to nonprofit organizations providing service dogs to the eligible veterans. This bill would ensure that veterans receiving service dogs through these grants are not charged fees and are provided with a veterinarian insurance policy for their service dogs. The bill would also establish a process for granting service dogs to veterans with mental health conditions and would authorize the Secretary to allocate up to $10 million annually for the program. This builds upon previous legislation, the Puppies Assisting Wounded Service Members, or PAWS, for Veterans Therapy Act, PL 117 through 37, which expanded efforts to support veterans with PTSD and other service-related injuries with service dogs. The VA refers veterans to nonprofit organizations to receive these service dogs, but the process can often be lengthy with veterans waiting up to 1 to 3 years, and the availability of the dogs is extremely limited. The SAVES Act aims to address these limitations and wait times by expanding the avenues that veterans can receive service dogs from VA to nonprofit organizations. Generally, nonprofit organizations are expected to provide these service dogs quicker than VA due to there being less bureaucracy. This legislation also looks at addressing the needs of our veterans. Amid that is why it expands the scope of the disabilities covered for the veterans who qualify for service dogs and will allow veterans who suffer from blindness, visual or mobility impairments, seizures, post-traumatic stress disorder, and traumatic brain injuries to qualify as well. Veterans face a wide range of issues, and there is never a one-size-fits-all approach. I am pleased to introduce this piece of legislation, or this bill, and it is bipartisan. It does have bipartisan support. Thank you.
Thank you, Representative Luttrell. Typically, we would go to the Democrat. The Democrat up to speak next is not here, so we're going to go to Representative Franklin. Representative Franklin, I now recognize you for 3 minutes.
Thank you, Madam Chairman. This is a solemn morning, as you noted, as we recognize the 23rd anniversary of the attacks on 9/11. That evil act of cowardice sent many of our sons and daughters to foreign soil to defend our nation. 2 decades now and trillions of dollars spent. An entire generation at this point of our young men and women who answered the call to join our armed forces to defend our great nation. Many of them have now joined the ranks of veterans who served in previous eras. And it's the duty of this panel, our primary duty, I would argue, to ensure that these brave Americans receive the best care and the benefits they've earned. Despite the sacrifices our veterans and their families have made, reports indicate they're being cut off from certain services the VA is obligated to provide them. Recently, the VA has been pushing more veterans back into VA facilities from community care providers, without consideration of continuity of care when deciding in a veteran's best medical interest. This abruptly cuts off veterans from long-time treatment plans and providers they trust. It's difficult for veterans to build rapport with a provider or a counselor and then be forced to find a new one, creating gaps in care. These gaps can negatively impact all aspects of life for veterans and their families. It's unconscionable this would be allowed to even happen, and that this committee would do so. It's something we must stop. I'm concerned by the comments by members of the committee that appear to be in direct opposition to community care. The same comments advocate shrinking the funding and size of the program. The rationale often centers around the VA's recent efforts to increase convenience with new clinics and improve care by recruiting new specialists. I applaud those efforts, including the opening of a fantastic new clinic in my hometown of Lakeland, Florida. But I consider those efforts to be table stakes. The VA should always be striving to improve. But excellent care at VA facilities and providing flexibility to veterans are not opposing missions. The VA must continue to improve care and expand convenience for our veterans. They deserve nothing less. But I believe, and I know many of my colleagues here agree, veterans should be able to choose the care that works best for them, whether that's inside the VA or out, especially for those who are already using community care. My bill, the Ensuring Community and Care and Veterans Health Act, protects veterans who have chosen to utilize community care. It will also provide clarity for veterans concerned that they'll lose their provider. Specifically, this requires the VA to consider continuity of care in determining best medical interest of a veteran. This will provide disruption in care for veterans already receiving services from community care providers. And most importantly, it will allow veterans to continue choosing the most convenient care for them. I'd like to thank the chairman for supporting this legislation, and I look forward to working with the community to mark up this bill in the coming days. I urge we take it to the House floor for a vote, and thank you, Madam Chair. I yield back.
Thank you, Representative Franklin. I now recognize Representative Vasquez for 3 minutes.
Thank you, Chairwoman Miller-Meeks and Ranking Member Brownlee, for allowing me to testify today in support of my bill, the New Mexico Rural Veterans Healthcare Access Act. Traveling across my district can take up to 9 hours, from Jal, New Mexico to Zuni Pueblo. That means that nearly 50,000 veterans who call New Mexico's 2nd District home have more difficulty accessing critical resources, including VA healthcare, which is largely contained in 2 veteran integrated service networks. However, in southern New Mexico, the lines don't work and veterans suffer. This problem has been occurring for over a decade. In fact, I started this fight as a staffer before I became a member of Congress. The current lines force veterans in Otero and Eddy counties to travel more than 4 hours to Albuquerque instead of nearby El Paso, less than an hour away, for health care. Traveling long distances for basic care, referrals, and other appointments creates an incredible hardship for those who served our country. And it's not just long distances, it's dignity of care and extended waiting times. The VA will only provide mileage reimbursement to veterans who seek service within their VISN lines. So a veteran in Carlsbad is faced with an unjust choice: get reimbursed for a 9-hour trip to their designated VA hospital in Albuquerque, or bear the cost themselves for a 4-hour trip to El Paso. Our veterans opt for the closest VA but are not receiving any mileage reimbursement for going outside their VISN lines, defeating the purpose of this system. And I recently met with both the directors of the Albuquerque and El Paso VA healthcare systems and brought the ranking member of the Veterans Affairs Committee to listen directly to veterans about the hardships that they face. And everybody in the room agreed that the line should be changed. So as legislators, we cannot leave our rural veterans behind. The Veteran Integrated Service Networks were created to make sure veterans are organized into a system where they have access to what they need. But for the rural veterans in my district in southern New Mexico, that benefit simply does not exist. My bill, the New Mexico Rural Veteran Healthcare Access Act, would move Eddy and Otero counties in my district into Veteran Integrated Service Line 18. This change would give these veterans closer access to specialty care and mileage reimbursement for the VA hospital trips that they are already making. To the veterans of New Mexico's 2nd Congressional District, know that I'm here fighting for you, whether you're in Eddy or Otero County, Doña Ana or Bernalillo. You all deserve equal access to the benefits that you deserve. I urge support for my legislation in this committee, and I yield back. Thank you, Ms. Chairwoman.
Thank you, Representative Vasquez. I now recognize Representative Self for 3 minutes.
Thank you, Chairwoman Miller-Meeks. I'm honored to introduce H.R. 9485, the Enhancing Faith-Based Support for Veterans Act of 2024. This important legislation addresses a crucial gap in the spiritual care provided to our veterans. Under this bill, VA chaplains would be required to offer veterans the option to order their name and contact information to be shared with non-VA religious or faith-based organizations of their choice. In other words, this option is at the sole discretion of the veteran. This step will ensure that veterans have access to the spiritual care they need and want, regardless of their faith. This issue was brought to our attention by a dedicated Army veteran who also serves as a Catholic Eucharistic minister in the Dallas Diocese. He learned of the problem through a parishioner who had been bringing Catholic communion to the Sam Rayburn Memorial Veterans Center and Bottom VA Clinic for many years. However, 2 years ago, they were informed that due to a change in policy, access to VA patients had been revoked. H.R. 9485 aims to fix these issues by allowing veterans to complete a privacy release form, similar to what all of our constituents have to fill out before opening casework. This will enable the VA to connect them with chaplains or religious leaders who can offer the specific spiritual support they need and want. By passing this bill, no veteran would be denied the spiritual care they require due to bureaucratic red tape. I am grateful to my constituent who brought this issue to light, and I look forward to working with my colleagues to advance this bill through Congress. I yield back.
Thank you, Representative Self. I now recognize Representative Gluesenkamp-Perez for 3 minutes.
Thank you to the chairwoman and ranking member for the opportunity to testify today about my bill, Rural Veterans Transportation to Care Act. Almost exactly 1 year ago today, I heard from one of my counties in my district that they had just received notice from the VA that they were no longer eligible for the VA Highly Rural Transportation Grant Program. The county had been operating a van for the purposes of transporting veterans to the Department of Veterans Affairs facilities to receive medical care, free of charge since 2014. Over the years, this service has proven essential to veterans seeking essential care to things like chemotherapy and critical surgeries, treatment for heart conditions. In 2022 alone, the van made approximately 300 trips and transported between 40 and 60 veterans. However, due to the definition of eligibility for these grants as set in statute, as fewer than 7 residents per square mile, Skamania County learned that due to new census data and migration changes that happened during the pandemic, that our rural county was no longer considered rural enough. Now we are at 7.15 residents per square mile, and with just 1 week's notice, we lost transportation funding. So I sent a letter to the Secretary of Veterans Affairs, McDonough, in October, urging the VA to fill transportation gaps for rural veterans and work with Congress to redefine highly rural. In a reply earlier this year, the department expressed support for the provision outlined in Rural Transportation to Care Act. The bipartisan bill would improve how VA measures rurality, helping more veterans living in rural areas get transportation to VA or VA-authorized healthcare facilities. The bill would also expand eligibility to both rural and highly rural counties, as well as tribal organizations. Lastly, the legislation would increase the maximum funding amount so transportation services could keep pace with inflation. It is our responsibility to our nation's heroes, ensure that our nation's heroes are well supported after returning from home and can access the benefits they have earned and deserve. Just last week, I was visiting with veterans in Pacific County about how vital these kinds of transportation services are, and they're literally life or death. People who have been waiting for appointments for 18 months can lose an appointment if they're just 10 minutes late or 15 minutes late to their appointment, setting them back 10 months to care. Access to professional, reliable transportation is critical to deliver life-saving care to our veterans. As veterans across my district and the country face dramatic reductions in life-saving services, it is our duty to make sure they are not left behind. This bipartisan bill won't only restore critical healthcare transportation services for Skamania County veterans, but will also newly expand eligibility to make sure more veterans in rural areas around the country have a safe and reliable way to get to their appointments and receive the care they deserve. I thank you again for the opportunity to testify on this bill, and I look forward to continuing to work on getting this across the finish line.
Thank you very much, Ms. Gluesenkamp-Perez. The chair now recognizes Representative Womack for 3 minutes.
I thank the Chairwoman Miller Meeks and Ranking Member Brownlee and distinguished members of this subcommittee. I want to thank you for considering my bill, H.R. 9324, the Protecting Veteran Access to Telemedicine Services Act of 2024. I'd also like to express my sincere gratitude for allowing me to speak in support of this legislation today. This bill seeks to ensure that our nation's veterans, whether they reside in bustling urban centers or in the most remote areas of our country, have uninterrupted access to the health care services they need and deserve. As you're aware, the Ryan Haight Online Pharmacy Consumer Protection Act was enacted in 2008 to regulate the prescription of controlled substances via telemedicine in response to the rise in online pharmacies and the potential for misuse. This law plays an important role safeguarding public health, but also has not been updated to reflect the differences between 2024 compared to 2008 and does not acknowledge the difference between VA and general civilian online pharmacies. During the COVID-19 pandemic, requirements under the Ryan Haight Act for a patient to meet with a practitioner in person for the prescription of a controlled substance were temporarily waived. The DEA and HHS announced a temporary extension of these flexibilities, but that extension expires at the end of this year. My bill, the Protecting Veteran Access to Telemedicine Services Act of 2024, would permanently extend this exemption to allow healthcare professionals employed by the VA to prescribe medically necessary controlled substances to veterans via telemedicine under certain conditions. This exemption has been a lifeline for our nation's veterans, and without a permanent exemption, many veterans could see their access to vital health care services severely restricted. For our veterans in urban areas, the expiration of this exemption would mean longer wait times for in-person appointments, further straining an already burdened VA healthcare system. The situation is even more critical for veterans in rural areas. These veterans face unique challenges, including geographical isolation and limited access to healthcare providers. The Ryan Haight Act exemption has enabled them to receive care from VA providers and specialists who may be hundreds of miles away without the need for costly and time-consuming travel. The continuation of this exemption is not just a matter of convenience, it's a matter of necessity. It ensures that veterans in every corner of this country have equal access to the care they so desperately need and they deserve. It's an honor to speak in support of my legislation today. I urge my colleagues on this subcommittee to support the bill, to act swiftly in passing this legislation. Our nation's veterans have sacrificed so much for our freedom. It's our duty to ensure they receive the care they've earned in a manner that meets their needs in today's world. And with that, Madam Chairwoman, I yield back my time.
Thank you very much, Representative Womack. The chair now recognizes Representative Tokuda for 3 minutes.
Thank you. Chairwoman Miller-Meeks, Representative Sherphyllis McCormick, and distinguished members of the Health Subcommittee, thank you for including my bill, H.R. 8562, the Parity for Native Hawaiian Veterans Act, in today's legislative hearing, and for the opportunity to speak in support of this important bill. In the United States, there are approximately 614,600 Native Hawaiian veterans, including nearly 275,000 in my home state of Hawaii. According to a May 2022 report by the Veterans Health Administration, Native Hawaiian and other Pacific Islander veterans aged 45 and older experience significantly less access to checkups and routine care than their white counterparts. The report concluded that work is needed to improve the veteran experience of care among Native Hawaiian and other Pacific Islander veterans, and better information could be helpful in understanding and addressing their disparities. They served and sacrificed the same as their fellow veterans, yet our country is failing to meet our obligations to them. More must be done to eliminate needless barriers to care for our Native Hawaiian veterans. That is why I have introduced the Parity for Native Hawaiian Veterans Act to ensure Native Hawaiian veterans can access health care services in a similar manner as their American Indian and Alaska Native counterparts. To fulfill the federal government's trust responsibility to the Native Hawaiian community, it is vital that Native Hawaiian veterans be treated the same as other Native American veterans and explicitly included in federal programs and policies supporting other Native veteran populations. Currently, the Indian Health Service, tribal health programs, and IHS-funded urban Indian organizations can seek direct reimbursement from the VA for services rendered to eligible American Indian and Alaska Native veterans. The Parity for Native Hawaiian Veterans Act would codify the same reimbursement relationship between VA and the Native Hawaiian health systems that have been authorized by Congress to provide comprehensive health promotion and disease prevention services, as well as primary health services to our Native Hawaiians. With more locations near to where Hawaiians live, this is about meeting our veterans where they are at and greatly increasing their access to care. My bill does three things. It updates the definition of Native Hawaiian in statutes governing veterans' care and benefits. It eliminates co-pays for qualified Native Hawaiian veterans, and it allows the VA to directly reimburse the Native Hawaiian health systems for care provided to Native Hawaiian veterans. This bill was developed in consultation with Papa Olakahi, which has been authorized by Congress to coordinate and assist healthcare programs and services provided to Native Hawaiians. The bill also incorporates technical assistance from VA and past work by the Office of Hawaiian Affairs. Ultimately, the Parity for Native Hawaiian Veterans Act is about improving healthcare access and affordability for Native Hawaiian veterans and ensuring all veterans are provided the care they need and are entitled to as a result of their service to our country. I look forward to working with members of this committee and Senator Hirono, who has introduced identical legislation in the Senate to advance this measure forward in Congress. Mahalo, and I yield back.
Thank you very much, Representative Dakota. The chair now recognizes Representative Chavez-DeRemer for 3 minutes.
Chairwoman Miller-Meeks and Vice Chair Phyllis McCormick, thank you for inviting me today to speak on behalf of my legislation, the VA Geriatrics and Gerontology Advisory Committee Expansion Act. This bill is simple. It would include a representative of the National Association of State Veterans Homes on the Department of Veterans Affairs Geriatrics and Gerontology Advisory Committee. NASVA has been great partners and supporters of this legislation. Their goal as an all-volunteer organization is to promote and enhance the quality of care and life for veterans and families in their network of homes through education, networking, and advocacy. There are 169 VA-recognized state veterans homes across the nation, including 2 in Oregon, 1 in the Dalles and 1 in my district in Lebanon, Oregon. The Geriatrics and Gerontology Advisory Committee was authorized in 1991. Its primary role is to advise the VA on geriatric research education and assess the demand for long-term veteran care and the VA's ability to provide for its plan to meet these geriatric services. A representative from NASVA having full representation on the committee would be able to bring new, unique, and tested clinical expertise to strengthen this mission. With over 8 million living veterans who are age 65 and older, many still from our greatest generation, there is an everlasting need to strengthen and expand long-term care options for our veterans. The amount of nursing home care offered by the VA is currently not meeting the overall number of eligible veterans. NASVA will be able to offer nursing home care experience combined with the ability to stretch adequate resources and serve as many veterans as possible, including expanding care to veterans who can be serviced in their own communities and homes. With a nationwide network, NASVA has the capabilities to understand the changing demographics, needs, and preferences of veterans in all areas of the country. I believe state veterans' homes have the full capability to advise the VA on the long care options. And I also believe the VA must also make a long-term commitment with state veterans' homes. I have appreciated the ongoing support of Chairman Bost and the committee here today, and thank them for their steadfast support and leadership in aiding our nation's veterans. They were kind enough to visit my district back in June to tour the Portland VA Medical Center, and also helped me hosting a listening session in Bend, Oregon, where we heard directly from local veteran constituents on the issues they face in receiving the care they deserve. One of the main issues we discussed was long-term and community care for the aging veterans. Further, I echoed those concerns of Oregonians veterans in writing to Secretary McDonough, asking the department to respond to a series of questions that were raised during that listening session by July 31. We have yet to receive that response from the VA. I urge Secretary McDonough to respond to these questions quickly because they are questions not coming from me. They are questions from our veterans, the very ones he was appointed to and confirmed to serve. Again, I want to thank my colleagues on both sides of the dais for their consideration of this legislation, and I urge their support. Passing the VA Geriatrics and Gerontology Advisory Committee Expansion Act will be a clear win for the state's veterans' homes network and for our nation's aging veterans. And with that, Madam Chair, I yield back.
Thank you very much, Representative Chavez-DeRemer. As is our practice, we will forego a round of questioning for those members waving on to present their bills. They've excused themselves, or they may now be excused. I now invite our first panel to the table. Joining us today from the Department of Veterans Affairs is Dr. Carolyn Clancy, Assistant Undersecretary for Health, Discovery, Education, and Affiliate Networks, Veterans Health Administration. She is accompanied by Dr. Matthew Miller, Executive Director, Office of Suicide Prevention, Veterans Health Administration, Dr. Ajit Pai, Executive Director, Office of Rehabilitation and Prosthetic Services, Veterans Health Administration, and Mr. Ryan Hyman, Acting Director, Member Services, Veterans Health Administration. Dr. Clancy, you are now recognized for 5 minutes to present the department's testimony.
Well, good morning, Chairwoman Miller Meeks and Acting Ranking Member Sherfless McCormick and members of the subcommittee. Thank you for the invitation to present our views on several bills that would affect VA programs and services. I'm not sure if we have name tags, so we'll just point out Dr. Matthew Miller, Dr. Ajit Pai, and Mr. Ryan Hyman, who are with me here today. Today's date, as noted by you earlier, Madam Chair, holds profound significance in our nation's history and for VA. 23 years ago, our nation was under attack, and in the aftermath, many brave Americans honorably answered the call to serve, creating a new generation of veterans, each with unique challenges and healthcare needs from nearly 2 decades of conflict. Our solemn duty is to ensure that all veterans receive the exceptional care and respect they deserve. The sacrifices and those of their families underpin our unwavering commitment to VA's noble mission. While we're prepared to discuss all proposed legislation, I'll highlight a few bills in these opening remarks. The No Wrong Door for Veterans Act proposes changes to VA's Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. Key provisions extend this program's duration, modify the definition of emergency treatment, and require baseline mental health screening for grantees using the Columbia Suicide Severity Rating Scale, also known as the CSSRS. The bill also requires annual briefings between grantees and VA Medical Center personnel. We support the bill's intent, but have concerns. We are opposed to codifying CSSRS use, as this could prevent adopting more effective future tools. Additionally, we recommend extending the pilot to allow the program to run a full 8-year period, and also recommend increasing authorized appropriations to reflect the extended program duration and allow nationwide scaling. Our teams are prepared to collaborate with your offices to incorporate these recommendations and others noted in the written statement. Next, H.R. 6291, Have You Served Act, provides a grant program encouraging human services professionals, state and local governments, and community providers to inquire about military service. This bill would authorize VA to make up to 25 grants annually, not exceeding $200,000 each, to eligible entities for developing or expanding Ask the Question campaigns. These campaigns are crucial to identifying and supporting veterans in various community settings. We support the bill's intent, but recommend technical and clarifying edits for successful implementation, including expanding the scope of eligibility and supported services. And other amendments would just be needed to provide VA with some flexibility in program administration. With respect to H.R. 6330, the Veterans Sentinel Act, Section 2A would require VA to establish a pilot program for a working group to collect and analyze data regarding on-campus suicides and attempted suicides. We support this section, but recommend technical edits to ensure optimal use of resources for preventing veteran suicide. We recommend that Congress avoid legislating a specific methodology or evaluation approach, allowing VA the flexibility to determine the best strategies and apply innovative solutions to address this critical issue. And as written, we anticipate significant implementation costs. Section 2B would require VA to annually evaluate statistical trends of suicides and attempted suicides by veterans that occur on VA property and determine recommendations for prevention, and we support this section, recognizing the need for timely and useful surveillance efforts to end veteran suicides. And we defer to the Comptroller General regarding Section 2C. Finally, we appreciate the committee's interest in 2 bills resembling legislative proposals in fiscal years 24 and 25 presidential budgets, H.R. 7504 and H.R. 9324, which would both make important progress in reducing barriers disproportionately affecting rural and otherwise underserved veterans. We support both bills. However, several technical and clarifying edits technically are needed to fully address the intended problems. Thank you for your ongoing support of programs supporting our nation's veterans. Your dedication has improved the lives of those who have served our country, and we look forward to working together with you to develop innovative solutions and develop emerging challenges to meet veterans' evolving needs. Your partnership is absolutely invaluable. Madam Chair, Ranking Member, this concludes my statement, and we're happy to answer questions.
And thank you very much, Dr. Clancy. Typically, I will reserve my questions until the end so that other members can go prior to me. So, Representative Sherfliffe McCormick, I now recognize you for 5 minutes.
Thank you, Madam Chair. Dr. Clancy, in your testimony, you suggest that Representative Brownlee's bill modified to provide greater clarity in terms of how the grant program would be administered, to include the application process, the award of grants, and requirements for applications. Could you elaborate on this? What kind of requirements for applicants would be most helpful to ensure grants are awarded to appropriate entities? Thank you.
Thank you for the question. As we've indicated, we fully support the spirit and the intention of the Have You Served, Ask the Question legislation. This is in direct reinforcement of Governor's Challenge goal number 1, which is to better identify veterans, service members, family members in the community, and in turn, connect them to care. I think the increased clarity that is requested around the application process, applicant requirements, awarding of grants, and use of grant funds can relatively easily and in a straightforward manner be worked through within the markup process, and our team stands by ready to offer suggestions therein.
Thank you. So my next question is for Dr. Clancy, but I guess you're directed to who can best answer it. As written, Representative Brownlee's Have You Served Act is pretty deferential to the Secretary on the topic of what VA resource grantees should connect veterans to. But in your written testimony, you recommend that the bill be amended to be more specific about the array of VA services and benefits to which grantees should connect with veterans. Can you expand on how you believe those services should be identified and why more prescriptive language would be helpful to VA in ensuring veterans can be connected with those programs?
Great questions. Thank you. Also for Dr. Miller.
I think it's a really good question. It's always a fine line between writing this in a way that is broad versus overly prescriptive to find the right balance and mix. I think the right subject matter expertise teams between the Veteran Experience Office and our Partnerships Office would happily sit down and talk about the specifics to strike that balance in a way that most fully supports the spirit and the intention of this bill.
Thank you. I think this question is going to be for you also, Dr. Miller. I appreciate VA's testimony on the Have You Served Act and the recommendations that the scope of eligible entities that can apply for these grants to be expanded. Can you speak to some of the work that the community partnership in the VA, in the Vet Resource Community Network, and the VHA National Center for Healthcare Advancement and Partnership, this bill might be able to help and support its and becoming law?
This bill, as it's currently written, speaks very directly, and I must say, from my perspective, I appreciate it as such, to the efforts being conducted through the Governor's Challenge. And it highlights efforts that 8 states and 1 U.S. territory are currently engaged in with Ask the Question and seeks to expand those efforts. But in the spirit of expansion, it also looks at and offers to look at other partnerships such as those that are engaged and structured through VEO and through HAP. It's opening the door to other partnerships beyond Governor's Challenge and drawing them in.
Well, I have a quick question. I want to shift towards Veteran Sentinel Act. Dr. Miller, I was glad to learn from your testimony that VA established an interagency work group to address GAO's recommendations regarding on-campus suicides. Can you share what the VA's existing intra-agency work group has done to improve VA's response on campuses suicide, particularly in improving processes? How long does VA intend to continue convening the working group, and would codify the working group help ensure this work continues?
3 improvements stand out to me to offer to you in response to your question. Improvement number 1 from the interagency work group is we have improved the process of the informational briefing system such that we've standardized the process across VHA, VBA, and NCA so that standardized information is included. Number 2, we've included in the process very specific checkpoints for asking, was an RCA conducted? Was a peer review conducted? Creating hard stops with those questions. 3, we've addressed direct needs that have been identified, parking lot signs being one. We, in FY23, provided parking lot signs to 100% of VA facilities. In FY24, we're offering 7,000 additional parking lot signs with the VCL number and 988 updates.
Thank you. I yield back.
Thank you very much. The chair now recognizes herself for 5 minutes. Dr. Clancy, the VA's testimony requests removing the statutory Cap 1 Fox grant amounts. VA has not properly managed grant funds within the first 2 years of the program, given that some organizations are receiving the full grant amount and serving less than 20 veterans a year. How do you justify removing the cap when the VA isn't properly overseeing these funds?
I'm happy to take that question, ma'am. Yeah. As the program that administers the Staff Sergeant Gordon Parker Fox Grant Program, I appreciate your question. I thank you for it. The request to adjust the cap is in response to adjustments to something we all have been talking about, inflation. So that the awards as it continues are reinforcing of current costs and adjust to current costs. I think panel 2 members noted the advantage of this as well within their written statements.
Thank you. Dr. Clancy, given the significant, and I realize that you may refer this, given the significant physical and mental health benefits of adapted prostheses and terminal devices for sports and recreational activities, why does the VA not support including these devices in the definition of medical services under Title 38?
This is Dr. Pai, who is the expert here. Thanks.
Good morning, Chairman. So we already include that definition of adaptive sports devices in our regulations, and our clinicians are prescribing them.
You said you include a definition, but does that definition mean that it doesn't mean that they're medically necessary?
Correct. So with adaptive sports, and let me say that we really appreciate the intent and the spirit of this legislation. These devices are highly complex, right? An individual with an amputation has to go through weeks, months, sometimes years of rehabilitation, and their medical comorbidities can impact their ability to utilize that device. We just had the Paris Paralympics, and we're really proud of our 13 veterans that we support over there. And what we see is that the rehabilitation for this type of journey can take even longer than just that initial phase. And so we really want to make sure that a veteran has consistent and constant participation in that activity so that they can really benefit for that lifelong care.
So I just want to make sure I understand this correctly. So you support the current regulatory framework. You're not opposed to these devices being utilized. So is the problem with codifying these provisions into law problematic because you're afraid veterans won't get the rehabilitative services that they need?
No, man. We just feel that the legislation is redundant because we're already doing that. And we understand that there are veterans out there that are having challenges, and we really want to make sure that we're hearing from those veterans, from those districts, from yourself and other congresspersons to make sure that we're caring for those veterans. And I understand that there's a question of, will one clinician prescribe something that another clinician may not prescribe? So we're really putting in efforts to educate our clinicians.
Right, thank you, which is why we need to have it codified into law. So thank you for that. I had another question in regards to the Have You Served Act, Dr. Clancy. And rather than setting up a new program, why can't grants be utilized for those entities that are already doing this? So in Iowa, we have veteran service organizations in every single county. Why could not these grants go to them? Or why could not these grants go to our great veteran service organizations, such as the Legion, Disabled American Veterans, Wounded Warrior Project, Purple Heart, VFW? There's too many. If I left you out, I do apologize. But why not give the grants to existing organizations who already work with veterans and are adept at that?
I think the short answer is we could certainly do that, and happy to work with your staff on that. At the same time, we would also like to recognize that there are places that are beyond the reach even of those phenomenal organizations and not preclude their contributions as well.
Oh, interesting. The smallest town in Iowa of 200 people has a VSO, but thank you so much for that. Seeing no other members, I think this round of questioning is over. Our second round of questions, do you have a second round of questions? Yes. Okay. The chair now recognizes Representative Sherfilis McCormick.
Thank you. I appreciate your testimony points. I appreciate that your testimony points out that while on-campus deaths by suicide are tragic, they are relatively rare among all suicide deaths. However, we have no way of knowing how many veterans' deaths by suicide may be occurring at community care facilities or their root causes. Would VA be able to apply the same investigation method in this bill, which is the Veterans Sentinel Act, to suicide deaths that occur at community care facilities if we are to amend the bill to include that?
Happy to answer that question. There have been 20 on-campus suicides to the present date this fiscal year. Adding information from non-VA sites applicable to veterans, I think, would be value added to our awareness and surveillance process. We would be very happy to take a look at what would be needed to engage that process with our community partners, yes.
Thank you. And I want to also talk briefly about the New Mexico Rural Veterans Healthcare Access Act. Dr. Clancy, in your testimony regarding the New Mexico Rural Veterans Healthcare Access Act, you mentioned that VA is taking action to address this issue. However, there are veterans currently electing to receive their care from the El Paso VA healthcare system because it is closer to them. However, in VA's eyes, they live within the catchment area of the Albuquerque VA and are therefore officially assigned to that facility and only receiving travel reimbursement when they travel to that facility. What actions, if any, can the VA take right now to address this without requiring VISN lines to be redrawn to ensure that veterans who are already doing this are able to get their transportation reimbursed?
A great question. Mr. Hyman.
Sure. Thank you, Ranking Member Sherfilis McCormick, and also thank you to Representative Vasquez for his testimony earlier. We agree with the interest of examining the particular lines. It's something that we do not feel we need a law to actually accommodate, and as such, we are currently looking into everything from referral patterns to transportation reimbursement, as you mentioned, and as Representative Vasquez mentioned. We are committed to this, and we intend to brief the committee as well as local delegations of these efforts in and around the end of the calendar year.
So does VA have any plans to adjust the VISN boundaries to account for these veterans? And if so, what is keeping the VA from doing this, doing as expeditiously as possible?
Thank you for the question. We are actively looking into what those boundaries could be. And I think certainly redistricting or reapplying the VISN structure and boundaries is something that is within our control and something that we're actively working at between VISN 22 and VISN 17.
And Dr. Clancy, I understand that your testimony that the SAVES Act, which would create a 5-year pilot grant program for nonprofit organizations to provide service dogs to veterans, would likely require new staff in a dedicated office. Do you have an idea of how many additional staffs would be needed to administer this program, and within which program office would VHA would you house these programs?
So I'll need to take that for the record, Congresswoman. I don't think it would be an enormous lift in terms of the number of staff, and I'm guessing it would probably come under prosthetics, but I don't want to speak for my colleague here. But we'll get back to you on that. He's about to say no.
Dr. Miller, can you explain more about why VA is concerned about the No Wrong Door Act codifying the Columbia Suicide Severity Rate Scale as the only tool Fox grant recipients may use to complete baseline mental health screenings? What is the current practice? What are some other possible tools that could be used? And how would limiting the program to Columbia Suicide Severity Rating Scale affect grantees and outcomes?
Thank you for the question. Let me be clear that the Suicide Prevention Program Office supports the Columbia as a scale from a validity and reliability perspective and sees the value of its role. I think our concern can best be summarized in terms of codifying it as the tool to use. If a more effective tool arises in the next 2 to 3 years, we want to be able to flexibly adjust to that, and our current bylaws allow for that, rather than an act of Congress literally to adjust from the Columbia to a different measure.
Thank you very much. I yield back.
Thank you very much, Representative Sherflis McCormick. The chair now recognizes Ranking Member Takano for 5 minutes if he has questions.
Thank you, Chair Miller-Meeks. Dr. Miller, we received VA's interim report on the Fox grant program that included some limited data on the effectiveness of the program so far. And we appreciate that VA anticipates having additional data in its final report and believe these data will help Congress and VA evaluate whether the program is working as intended. Do you believe that limiting grantees to the Columbia Suicide Severity Rating Scale would impair the level of data that grantees can collect and therefore limit our ability to assess the effectiveness of the program if we reauthorize it?
Thank you for your question, sir. Good to see you. Yes, we do believe that limiting to the Columbia would impact the reliability and the validity of outcome evaluation of the Fox program. With that said, we do not necessarily read in the legislation that outcome data is restricted to the Columbia necessarily, as there are other measures and broader measures of well-being, mental health, financial status that will also be included in the outcome measures as part of the Fox grant program.
Okay. Well, I want to kind of switch gears here and talk about HR 9426 to carry out a pilot program under the Secretary, under which the Secretary may fill vacant shifts at medical facilities of the Department of Veterans Affairs with non-departmental healthcare providers. And while I appreciate my majority counterpart's intent in putting forth a bill that would allow VA to use contractors to cover vacant shifts at VA medical facilities. I share VA's concern that key aspects of the bill are not clearly defined and the implementation would be difficult. However, knowing that staffing shortages are often a concern for medical centers, I'm glad to hear that our VISNs are already offering clinical resource hubs to ensure staffing needs are met in times of vacancies. Can you expand on how that is activated and if it has so far been sufficient to address shortages?
So I will give you a couple of examples. The notion is if a veteran, for example, is seen at Detroit and by a primary care clinician who then believes that that clinician needs a specialist, but that specialist is not available or they don't have the capacity to see that veteran in a timely way at that facility, through this clinical resource hub, they can identify another facility in the network where the veteran could get that care. This has worked extremely well, as I understand it, in VISN 23, which is Minnesota, Iowa, South Dakota, and North Dakota. And it's allowed them to bring much more of the cardiology care back into VA. Obviously, areas in all of those states where there are not cardiologists everywhere. And it also works very well on a number of other networks. But that's the intent of in other words, the VISN is more than just a silent overseer, if you will, of multiple freestanding facilities, but really is leveraging their capability as a system within a system, if that makes sense.
Dr. Clancy, are these in this example you gave, would the cardiologist, would that be a VA doctor or maybe potentially a contract doctor?
A VA doctor.
Okay. And that's through it's called a clinical resource hub.
Yes.
How does VA currently decide how and when to activate contracts with temporary help service firms?
We have put together a new contract, I think a year and a half ago, the Interim Critical Staffing Program, where we can hire a whole array of medical, nursing, and other healthcare specialties as needed, and that would be activated by individual facilities. It can also activate administrative and managerial support as needed as well.
So to what extent are these already in use?
I'd have to take that for the record and get back to you, sir, because it became live shortly before we realized that we needed to be more strategic with hiring and so forth.
Madam Chair, I have a couple of more just follow-up questions, or do you want to just kind of stop now? Prefer now? Okay, all right.
We're at our second round of questions already.
All right, that's fine. I'll yield back.
Thank you very much, Ranking Member Takano. On behalf of the subcommittee, seeing that no other members are here, I want to thank all of you for your testimony and for joining us here today. You're now excused, and we'll wait for a moment as the second panel comes to the witness table.
Madam Chair, I had one quick question. Congressman Representative Yehuda from Hawaii made a point today which clarified an issue for us, which may require a correction or addendum to the written statement. Is that feasible?
I think that you could submit that for the record.
Perfect. Thank you.
Ask Dr. Clancy about, so in the terms of Kim.
Welcome, everyone, and thank you for your participation today. On our second panel, we have Mr. Brian Dempsey, Director of Government Relations for the Wounded Warrior Project, Ms. Missy Meyer, Director of Community Integration at America's Warrior Partnership, Mr. Clark Pennington, Chief Operating Officer at the Independence Fund, and Mr. John Retzer, Deputy National Legislative Director for Health at Disabled American Veterans. Mr. Dempsey, you are now recognized for 5 minutes.
Thank you. Chairwoman Miller Meeks, Ranking Member Takano, and distinguished Health Subcommittee members, thank you for inviting Wounded Warrior Project to testify at this morning's hearing to discuss legislation intended to improve VA's ability to provide better access to care and ensure better health outcomes for our nation's veterans. Honoring and empowering wounded warriors has been at the heart of our mission since 2003. Meeting the needs of those who volunteer to serve our nation and protect the freedoms we enjoy as Americans is not only a solemn obligation, but a national priority. Our written statement reflects our views on several of the bills before you, but for today's hearing, on the anniversary of the September 11th attacks that led to our founding, I'm going to focus on legislation that we believe will be most impactful on the lives of the post-9/11 wounded, ill, and injured warriors that we serve. First, we support H.R. 9438, the No Wrong Door Act, which would reauthorize the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program through 2027 and extend an important tool for VA to provide upstream suicide prevention services in communities around the country. We remain hopeful that the Fox Grant Program becomes a permanent fixture in VA's public health strategy. However, we believe that attention should be given to how service eligibility determinations are made and how clinical care can be responsibly provided before the program is made permanent. To that end, we support adoption of the Columbia Protocol for baseline mental health screenings, which we use at Wounded Warrior Project for the same purpose. Second, we support H.R. 9427, legislation that would allow VA to provide grants to nonprofit organizations to provide outpatient mental health treatment services to veterans. While we appreciate the need to keep VA as a coordinator of unfragmented clinical care, we believe that embracing grants to direct care programs is a commitment most consistent with putting the needs of the veteran first, particularly when skepticism towards VA in the veteran community is an unfortunate reality for some. We believe this legislation can be thoughtfully incorporated into the No Wrong Door Act so that grants are carefully coordinated with other community-based efforts to help serve an overarching intent to connect veterans to the care and support they need now, but also foster a healthier awareness of and trust in the VA services that are available. Third, we support draft legislation to include a representative of the National Association of State Veterans Homes on the Geriatrics and Gerontology Advisory Committee of the Department of Veterans Affairs. VA's long-term support services reached just over 500,000 veterans last year, and 30% were under the age of 65. While we don't have figures to definitively state how many of these younger veterans served after 9/11, one of Wounded Warrior Project's most significant programs, the Independence Program, supports warriors with moderate and severe traumatic brain injury symptoms or other debilitating injuries or illnesses for whom independent living may be far from assured in both the near and long term. The need to plan for their futures and the present needs of aging veterans is more important than ever, and we need to ensure that critical stakeholders in VA's long-term support service portfolio have a voice in that planning. Shifting attention to veterans whose injuries may be more evident, we are proud to support H.R. 9478, the Veterans Supporting Prosthetics Opportunities and Recreational Therapy Act. This bill would raise adaptive prostheses and terminal devices for sports and other recreational activities to the same level as wheelchairs, artificial limbs, and special clothing as far as how VA is prepared to assist veterans on their path to a new normal. Under current law, VA will not provide adaptive recreation equipment to a veteran unless it's part of a medical or rehabilitative treatment plan. This legislation would effectively remove this barrier between a veteran and the support they may need to pursue activities like biking, swimming, or weightlifting that can be every bit as beneficial to mobility and mental well-being as clinical or guided rehabilitative care. We are proud to support this legislation because we have seen firsthand the positive and life-changing effects of adaptive equipment on a veteran's quality of life and mental health. Lastly, I would also highlight the needs of post-9/11 veterans with traumatic brain injury as a basis for our support for H.R. 7504, the Rural Veterans Transportation to Care Act. Traumatic brain injuries and related neurocognitive impairment can challenge, if not totally eliminate, a veteran's ability to travel to and from VA medical appointments. Some may rely on caregivers, but extensive commutes can add to the stress of caring for a loved one. Others may rely on public transportation, which can be very tedious and time-consuming if it's even available in the rural areas where they live. The Rural Veterans Transportation to Care Act would expand access to VA's highly rural transportation grants to veterans residing in rural areas. This VA grant-based program currently only helps veterans in highly rural areas travel to VA or VA-authorized healthcare facilities, but there are clearly many more who could benefit from this critical service. Ladies and gentlemen, it is my distinct honor to be here to represent our nation's wounded warriors and their families. Thank you for letting us do our part to keep the promise. This concludes my testimony, and I look forward to your questions. Thank you.
Thank you, Mr. Dempsey. Ms. Meyer, you are now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Takano, thank you so much for the privilege of being here today to testify. There are 2 bills that I would like to discuss today. First, America's Warrior Partnership is in support of H.R. 9427, introduced by Chairman Boss to carry out the pilot program to provide grants to outpatient mental health facilities. The more our nation can expand access to mental health care for veterans, the better. But it must be done with a holistic approach. Every veteran is unique. Offering counseling is wonderful. Additional choices such as outpatient facilities for mental health, access to traumatic brain injury treatment since it is often concurrent with a mental health crisis, and post-traumatic growth training can expand the resources that are available. The main focus of my testimony today is going to be on the No Wrong Door for Veterans Act. AWP is focused on outreach to all veterans, and as we told the committee last year, the original idea of the SSG Fox grant had a singular goal: find veterans in the community that need help and help them. To reach that goal, Congress needs to implement reforms that specifically bring back outreach as the singular focus, streamline the intake into the VA for eligible Fox participants, and hold organizations accountable. We're thankful for the committee's hard work on this program, and we offer a few observations and suggestions. As one of 80 grantees, we have done a significant amount of outreach since Fox inception. Currently, we have screened 1,917 warriors for the risk of suicide using the Columbia Suicide Severity Rating Scale, or the CSSRS. 370 of those warriors discussed and disclosed some level of suicide risk or a previous attempt. It's 19%. 94% of the warriors that have turned to AWP with their thoughts and trusted us with the risk of suicide were not seeking assistance for a mental health-related issue. The SSG Fox program is working. Relationships are being built and connections to resources are made. The Fox grant is a success story, and asking the question works. AWP, the VA, and Congress have all played an integral part in saving the lives of these warriors, but there is more to do. First, we are thankful for the inclusion of language that directs briefings for VA employees in regard to the SSG Fox program, and ensuring a bi-direction, solid working relationship with local VA staff is essential. It's more important than ever that we have education for frontline staff at the VAs to understand this program and its purpose. While the legislation mandates the CSSRS as the only required screening protocol, AWP recommends also adding language that would make the additional baseline assessments discussed earlier as optional. Rarely do veterans in our program complete all 5 of the additional baseline assessments, and very rarely do they complete them twice as required. The assessments have been described as both triggering and redundant by both our staff and the warriors that they're being administered to. Third, the emergent care section is very helpful. AWP recommends adding a section that clearly lays out expectations for the program and identifies boundaries for both the VA and the grantees. The SSG Fox Grant program is about outreach. However, the line has become muddied and expectations can be unclear. To fix this, it would be helpful to add a section that requires a specific program on-ramp for veterans identified as eligible and in need of VA care. The process doesn't need to be complex. It doesn't need to be burdensome. It can be done through the 988 crisis line. It can be done through local VAMCs with expedited care, or even a dedicated line for grantees to call when we have an eligible participant. The key here is expedited. If we're going to ask the question, we need to have a plan for the answer. Fourth is accountability. The Fox Grant program is working, and to keep the program successful, Congress and the VA must hold organizations accountable with verifiable metrics. AWP recommends adding a section requiring the VA to develop accountability metrics in regard to outreach, screenings, eligible participants identified in the course of the program, referrals, etc., and then require regular reports back to Congress. While accountability and metrics are vital, the data collection tool implemented by the VA at the end of 2023 has had the opposite of its intended effect. The Fox Grant program's assessments are meant to be anonymous, but currently the tool requires a social security number and a date of birth to enter any data into the tool. This has caused AWP to go from reporting nearly 100% of our data to less than 5%. AWP has suggested returning to the original anonymous participant identification numbers instead of requiring our warriors to provide personal health information to be in the program. Finally, the only limitation AWP has on being more successful is funding. If the ceiling on grants was doubled tomorrow, so would our outreach efforts. For these suggestions, please see our written statement that we've submitted. Thank you for the opportunity to testify, and I look forward to any questions you may have.
Thank you, Ms. Meyer. The chair now recognizes Mr. Pennington for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Takano, and distinguished members of the subcommittee. On behalf of Sarah Verardo, CEO of the Independence Fund, thank you for the opportunity to testify before you today. The Independence Fund was founded in the halls of Walter Reed to serve catastrophically wounded veterans, their caregivers, and their families. While the Independence Fund submitted written testimony on most of the bills before the subcommittee, I will limit my remarks to 2 pieces of legislation that impact our constituency the most. In 2017, VA promulgated a regulation entitled Prosthetics and Rehabilitative Items and Services under 38 CFR Part 17 that specifies when adaptive creative recreation equipment within prosthetics may be approved. The regulation cites an item that is designed to compensate for, or that may, by design, compensate for loss of physical, sensory, or cognitive function and is necessary for a veteran to actively and regularly participate in a sport, recreation, or leisure activity to achieve the veteran's rehabilitative goals. This definition appears to cover items like a running blade, climbing blade, a swimming or diving prosthetic, among others. However, the regulation potentially limits VA's approval at a local level of such an item for a veteran unless it is part of a medically necessary rehabilitation plan to meet a medical goal. And not for a long-term life or health plan, and a routine solitary or group activity for what VA states is only for personal enjoyment. The wording of that regulation has the potential to bias VA practitioners and VA employees in the prosthetics approval chain from allowing these devices to be approved, ordered, manufactured, or provided to veterans who seek to remain active throughout their lives beyond the rehabilitation phase. The very nature of this regulation appears to be at odds with VA's often invoked philosophy around whole health of the veteran and the VA's implied mission to help veterans heal and incrementally or ultimately achieve some degree of self-actualization and self-worth despite their medical history. The idea of using whole health approach to medicine is an important aspect of improving mental health and reducing suicide. Because of the disparity between VA's whole health philosophy and the regulation it imposes, limiting when veterans can obtain adaptive prosthetics, the Independence Fund is pleased to support Chairwoman Miller Meeks' legislation that will amend Section 1702, subparagraph 6, to specifically include adaptive prosthesis and terminal devices for sports and other recreational activities to the list of medical services VA must provide. This legislation will ensure veterans seeking to enjoy and benefit from physical and psychological aspects of recreational activities will now be guaranteed access to the prosthetics they need to thrive. The Independence Fund encourages the committee to quickly pass this legislation. Suicide prevention is one of VA's stated healthcare priorities. In 2020, Congress passed into law Commander Scott John Hannon Veteran Mental Health Care Improvement Act. Included in that act is the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant, which provides grant recipients the means and authority to evaluate suicidality through a mental health assessment. In the case, the veteran is deemed to need access to immediate higher-level mental health care due to acute suicidal crisis. The statute requires the Secretary to furnish that care. What is missing from the statute is a time requirement in which that care must be placed. Along with reauthorizing the grant program, the No Wrong Door for Veteran Act mandates that if the Secretary cannot provide the emergent care within 72 hours, the veteran will be deemed eligible for emergent suicide care under paragraph 1720J of Title 38. This is a much-needed provision. Veterans who are in acute crisis don't have days or weeks to be placed in a care setting that can address the crisis. This legislation will ensure that every care option is used so veterans aren't left on their own while they are in the greatest period of need. The Independence Fund fully supports the enactment of this legislation, and this concludes my testimony, and I am happy to answer questions.
Thank you, Mr. Pennington. Mr. Retzer, you're now recognized for 5 minutes.
Chairwoman Miller Meeks, Ranking Member Takano, and Member Bergman. Thank you for inviting DAV to offer our views on the Veterans Healthcare bills being considered by the subcommittee today. Many veterans do not recognize their veteran status and are not receiving care and benefits through the Veterans Health and Benefits Administration and community services. By asking, have you served? Healthcare providers, community partners can identify veterans who might otherwise go unnoticed and ensure they receive tailored healthcare, access to benefits, and community services. For this reason, DAV is pleased to support H.R. 6291, Have You Served? Data is essential for preventing veteran suicide by identifying at-risk individuals, tailoring interventions, and monitoring trends. Leveraging data enables VA to comprehend veteran suicide complexities, devise effective prevention strategies, and ultimately save lives. Therefore, DAV supports H.R. 6330, the Veteran Sentinel Act, but recommends expanding its scope to also include collecting suicide data for veterans using the Veterans Community Care Program. 2.7 million rural and highly rural veterans confront unique obstacles in accessing VA's top-notch healthcare services. DAV supports H.R. 7504, the Rural Veterans Transportation to Care Act, that would modify the existing transportation grant program to improve access to healthcare for rural veterans. H.R. 9324, the Protecting Veterans Access to a Telemedicine Service Act, would enhance telehealthcare accessibility for veterans in remote or underserved areas by eliminating the in-person visit, requirement for prescribing certain controlled medications. DAV supports this bill as it would guarantee continuous medication access for veterans, regardless of their ability to physically go to a VA facility. H.R. 9427 would direct the VA to carry out a pilot grant program for non-VA outpatient mental health facilities to ensure the delivery of culturally competent, evidence-based mental health care for veterans. Rather than creating a parallel system with little oversight and potential lower standards of care, we recommend increasing the number of VA mental health clinicians to reduce the wait times for mental health care in VA and veteran community care program settings. The recent VA Red Team report emphasized the need to expand the use of VA direct health care and balance the use of community health care services to prevent the erosion of the VA healthcare system. Madam Chair, H.R. 9438, the No Wrong Door for Veterans Act, would amend and reauthorize the VA Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program. DAV has no concerns about the provision to reauthorize the Fox Grant Program for an additional 3 years. However, the bill would also establish a new access standard, mandating a 72-hour deadline for the VA to provide services after a veteran is referred to non-suicidal mental or behavioral health follow-up care. Although we prioritize timely access to mental health services for veterans, this provision may risk disconnecting them from VA and other necessary support services. For these reasons, we do not support this provision of the bill. DAV supports H.R. 9478 to include adaptive prosthesis and terminal devices for sports and other recreational activities in VA's medical service package. These devices will help to promote physical activity and overall well-being among veterans, allowing them to engage in sports and recreational activities that they need and enjoy. DAV supports the Safeguarding VA's Healthcare Workforce Act, which would allow VA to bring in outside healthcare providers when they need to fill vacant shifts, ensuring enrolled veterans have timely access to care. However, we highly recommend VA prioritize its efforts to maintain proper hiring and retention practices, strengthen internal staffing levels, and remain the primary provider and coordinator of care while effectively utilizing community care networks. Finally, DAV supports the Service Dogs Assisting Veterans SAVES Act that would establish a pilot program to award grants to nonprofit organizations to assist in providing service dogs to eligible veterans. This bill would also ensure prescribed service dogs are provided at no cost, that there is reimbursement for any required follow-up training, and as well as coverage of veterinary benefits for the life of the service dog. Chairwoman Miller Meeks, this concludes my testimony, and I'm pleased to answer questions you or members of the committee may have.
Thank you very much, and thanks to all of you for your thoughtful comments. I now recognize General Bergman for 5 minutes.
Thank you, Madam Chair. And thanks to all of you for being here today and your thoughtful, articulate, and timely testimony. Not only timely in the subject at hand, but maintaining yourself within the standards of time. That's, you didn't waste any time, you got right to the point. I'd like to focus on two important bills that will help improve veterans' access to mental health care and suicide prevention programs. First, the No Wrong Door for Veterans Act, which I joined Chairwoman Miller Meeks in introducing last month. Despite spending more and more money each year on VA suicide prevention programs, more and more veterans continue to take their lives every day. There is it leaves a hole, not only, I know, in the family's heart, but it leaves a hole in those of us, and you included, trying to do the right thing for the right reasons for our veterans. And it takes a little bit out of every day knowing that we're still dealing with this. The Fox Grant Program, which I helped to champion during the 116th Congress, complements VA's existing suicide prevention efforts by targeting veterans outside of the VA system and ensuring that those in need are able to receive evidence-based care. The No Wrong Door for Veterans Act will reauthorize and improve the Fox Grant Program so that more veterans can continue to receive the suicide prevention that they need. Prevention care, that was, not just prevention. Secondly, I'd like to highlight Chairman Boss' Veterans Mental Health Access Act, which would create a pilot program to increase veterans' access to behavioral health care in the community. Both of these bills would make real changes to address the veteran mental health and suicide epidemic while protecting and complementing the important work of the VA. So now for questions. Ms. Meyer, could you speak to the bureaucratic barriers at VA that might prevent a veteran from receiving mental health or suicide prevention care?
Thank you for the question. So the barriers tend to be twofold. One of them being the requirements of the program to be enrolled, participating in the lengthy and sometimes, well, most of the time redundant, baseline mental health screenings. So we may have a veteran that is qualified based on the CSSRS, however, they don't want to participate in 4 or 5 other baseline assessments, so they're now ineligible. So they wouldn't be then enrolled in the Fox Grant program. AWP will still refer them to the VA.
Okay, do you think that bills like Chairman Boss' Veterans Mental Health Access Act will give more options to veterans who need mental health care?
We hope so.
Okay. Mr. Pennington, how has the Fox Grant Program improved veteran access to suicide prevention care?
Well, I would say that the Fox Grant is obviously an opportunity for organizations to capitalize on that funding to move their programs forward. At the Independence Fund, we do not typically take part in that in our suicide prevention. Our Operation Resiliency program is a program that is funded through 100% donations, but the Fox Grant in enabling us to also reach out to organizations like law enforcement and using that opportunity to educate law enforcement, who is typically our first responders on site with somebody who is in crisis. That is a huge opportunity for us under the Fox Grant.
Okay, so I'm going to interpret, but what you said is that the reforms to the Fox Grant Program included in H.R. 9438 will actually improve and broad-based, more broad-basing of these efforts and hopefully targeted to appropriate and much-in-need veterans.
Yes, sir.
Okay, and with that, Madam Chair, I know there was a couple of hearings ago I went over my time, so I'm going to yield back 35 seconds.
Thank you very much, General Bergman. I now recognize myself for 5 minutes. Mr. Dempsey, can you elaborate on the benefits of requiring the baseline screening to be conducted using the Columbia Protocol in terms of streamlining intake and standardizing data collection as specified in the reauthorization of the Fox Grant Program?
Of course, thank you, Madam Chair. Our perspective on that bill and using the Columbia Protocol is very much rooted in our own personal experience at Wounded Warrior Project, where our largest programming investment has been in the delivery of mental health support and related care. We recently established a triage team to help assign veterans to several programs within a continuum of support. The Columbia Protocol has allowed us to quickly and effectively screen veterans for their risk of suicide and help assign them to the appropriate level of care. I think it's the efficiency that you can move through and screen that has been the most beneficial aspect of us, but I'd be happy to follow up with colleagues of mine who work with warriors directly and that screening mechanism to perhaps provide some more insight on just how effective that's been for our organization. Thank you.
Thank you. Ms. Meyer, as you know, many VA medical facilities are not aware of the Fox Grant program. Can you tell me why you think the quarterly briefings in this bill would build partnerships between the community and the VA, as well as increase care coordination and ultimately provide better care to our veterans?
Yes, ma'am. Thank you for your question. I think that the quarterly briefings would be successful when you become a grantee, you're required to reach out to all the suicide prevention coordinators within your community. And so we've done that. And then the gap so far has been that then the frontline staff answering the phone has no idea when I call and say, hi, I'm a Fox grantee and I have a Fox participant. They don't even know what that is. And so making sure that they understand, knowing who we are when we make the phone call, knowing why we're calling to serve that veteran immediately would just, I think it could change the intake process completely.
Thank you. And Mr. Retzer, the HR 9324, Protecting Veterans Access to Telemedicine Services Act of 2024, how do you believe this bill would better serve rural veterans who may not have a VA provider within a reasonable driving distance?
Thank you for that question. Very good question. We look at the situation as our veterans that are in challenges with barriers for geographic location or even climate, that they may not be able to make their way to VA all the time. And that brings a risk when there's a deadline to get their medications on time. Many of the medications that they're taking actually are much needed for life-saving purposes and actually have some risky side effects if they don't have that continuity of care from their medication. So that is one of the things that we see, the advancement use of telemedicine to be able to facilitate that gap and barrier.
Thank you very much. And Mr. Pennington, in regards to HR 9478, the Veterans Sports Act, you have noted concerns about VA's policy of not providing adaptive recreation equipment such as adaptive prostheses or terminal devices when the equipment is intended solely for recreation. How many veterans have you heard from who were denied such equipment due to this policy? And could you provide any specific examples of veterans who are affected by this limitation and the impact it had on their physical, and even more importantly, their mental or emotional well-being?
Yes, ma'am, thank you. In reference to that, I mean, you can look back to a survey that we conducted in 2021, where we reached out to a significant population within our constituency that is seeing a significant reduction in the opportunity for recreational prosthetics. I can bring two examples to you right now that we are currently working with the VA on that has specifically requested swimming blades, specifically requested opportunities to continue recreational opportunities and activities that they did prior to their injury that they no longer can do because of their injury and therefore is impacting their mental health. Because of some of the restrictions and not just the fitting of a prosthetic to the individual initially, then the opportunity to have access to recreational prosthesis is a significant mental health barrier for them. We saw a significant decline in at least both of these that we have access to and that we've presented to the committee before in the past, that we really believe that this opportunity improves their mental health. And I did hear from the VA during their testimony here today that they believe this is already part of their process. I would say that the information coming from that level down to the practitioners inside of those VISNs is not happening because they are being denied access to these recreational prosthetics that ultimately go to mental health improvement.
Thank you very much. As a doctor and a veteran, I can certainly testify to the need for making people whole, similar to what their lives were before their injuries. Seeing that no other members are here, I would recognize the ranking member for closing remarks, but he's not here. On behalf of the subcommittee, I want to thank you all and all of the witnesses for being here today. I look forward to working with you and with the VA to address some of the issues facing our veterans and some of the points brought up today in testimony. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. I want to thank the members and witnesses for their participation to date. This hearing is now adjourned.